The OSCE places clinicians in a paradoxical environment. You are assessed simultaneously on natural human empathy and your capacity to extract rigid diagnostic data. Focusing exclusively on rapport risks losing control of the clock and missing mandatory criteria. Conversely, treating the encounter as a rote checklist results in clinical coldness, alienating the patient and failing conduct standards. A successful interview requires a strict underlying architecture to prevent the clinical conversation from becoming disorganized. To navigate the time pressure, we map the 12-minute station into a timeline of 6 distinct modules. The first minutes cover the opening, transition management, and the continuous mental status exam. The second half handles medical rule-outs, differential diagnoses, and the final verbal handover. Delegating the data collection requirements to this fixed structural logic preserves the mental bandwidth you need for genuine empathetic engagement. Your 10 minutes of reading time is when the clinical work begins. You must pre-identify likely diagnostic clusters, note the mandatory rule-outs, and scaffold your handover on paper before entering the room. Move 1 is a warm introduction that orients the patient. You state your name and role, define the time limit, and seek permission to proceed. Move 2 employs a broad, unstructured question. Can you tell me in your own words what's been going on for you? To give the patient the floor. This initial free narrative provides immediate evidence of the patient's affect, speech patterns, and cognitive coherence in their natural state. Move 3 concludes the opening. Before shifting to structured questioning, you reflect back a summary of what you heard to confirm rapport. Cautionary: starting the interview with closed questions shuts the patient down. This limits your observational data and prevents you from seeing how the patient organizes their own story. These 3 moves establish clinical control while ensuring the patient's narrative drives the beginning of the encounter. After the 2-minute mark, the clinician must take the steering wheel. You begin a process of structured steering to ensure all diagnostic criteria are explored. While you steer the conversation, the mental status exam runs as a background process. You are observing these 7 domains as you converse. You observe psychomotor activity and speech rate to distinguish between the retardation often seen in depression and the agitation characteristic of mania. You are checking for affect congruence. This involves comparing the patient's observed emotional expression against their reported mood to see if they align. When querying perceptual disturbances, such as hearing voices, frame the question sensitively as an experience people sometimes have during difficult times. Assessing insight is a strict requirement for OCD, body dysmorphic disorder, and psychotic disorders. You must determine if the patient understands the nature of their symptoms. These integrated observations provide the content for the current symptoms section of your final handover. Failing to rule out substance use or medical history is a documented fail point on the OSCE rubric. Every DSM-5 TR category includes a substance or medication-induced specifier. Anxiety, mood changes, and psychosis can all be caused by direct physiological effects. You must ask 3 questions in every station. Are they on any medications? Do alcohol or substances feature in their life? And have they had any recent physical health changes? Weave these questions into transitions. If a patient mentions heart racing or sleep issues, ask if caffeine, medications, or alcohol might be contributing to those physical sensations. Reporting negative findings in the handover proves that you have considered all physiological causes for the presentation. These rule-outs fulfill the prerequisite for any primary psychiatric diagnosis. As the interview progresses, you use the gathered data to resolve clinical differential pairs. This table compares disorders on the schizophrenia spectrum. One common pivot point is the distinction between schizophrenia and schizoaffective disorder. A diagnosis of schizoaffective disorder requires delusions or hallucinations for at least 2 weeks in the absence of a major mood episode. The boundaries between the anxiety and OCD spectrums are also clearly defined. This list shows the distinctions between generalized anxiety disorder and OCD. While both involve intrusive thoughts, generalized anxiety disorder is characterized by uncontrollable worry across multiple domains, whereas OCD involves ego-dystonic thoughts and compulsive neutralizing behaviors. In feeding and eating disorders, weight is often the primary differentiator. This reference shows that anorexia nervosa requires significantly low weight. To distinguish binge eating disorder from bulimia, you must look for compensatory behaviors like purging. Binge eating disorder is defined by their absence. Mastering these specific pivot points allow you to justify and defend your diagnostic choices in the handover. The verbal handover serves as a concentrated 3 to 5 minute demonstration of your clinical reasoning. You follow a fixed structure: referral, symptoms and MSE, relevant history, primary diagnosis, differential exclusions, and the close. Section 4 uses the state then support rule. You name the diagnosis first, then cite specific DSM criteria and the duration of the symptoms. In Section 2, you integrate your mental status exam observations, such as speech rate and affect, to build a cohesive picture of the patient's current presentation. This structured handover provides the examiner with the evidence required to verify your competency. Section 5, the differential exclusions, is where the logic of your diagnostic process is most visible to the examiner. You state the differential, acknowledge the symptoms that made it a consideration, and identify the specific criterion that was missing to rule it out. You conclude the station by restating the primary diagnosis and providing the immediate next steps for the patient's care. When you control the clock and allow the specific criteria to drive your reasoning, the diagnosis proves itself.